Good afternoon. Thank you for having me. I know everyone's tired and ready for happy hour, so appreciate your attention. My name is Andrea Stroud. I'm from University of Wisconsin, and I'll be presenting our abstract called Psychosocial Factors Are Associated with Quality of Life After Laparoscopic Anti-Reflux Surgery. Just hit the green button. Okay, sorry. I have no disclosures. Nearly 2/3 of U.S. adults will experience gastroesophageal reflux in their lifetime. While many patients respond well to lifestyle modifications and proton pump inhibitor therapy, a number of patients still are still affected by persistent reflux symptoms and regurgitation. Laparoscopic anti-reflux surgery is the gold standard for medically refractory GERD patients. Numerous descriptions exist of the safety and efficacy of these procedures. However, there's more limited data when it comes to patient-reported outcomes after laparoscopic anti-reflux surgery. We sought to examine the association between preoperative patient characteristics and postoperative GERD-related health quality of life in patients who underwent laparoscopic anti-reflux surgery. And we also examined which factors were predictive of a higher postoperative quality of life. All patients undergoing benign foregut surgery in our division of minimally invasive surgery at the University of Wisconsin are entered into prospective institutional database. We performed a retrospective analysis that included all patients who had a complaint of reflux and who underwent primary laparoscopic anti-reflux surgery between June 2010 and November 2015. We excluded reoperative patients and those patients who had a fundoplication for another indication, such as achalasia. All patients fill out a preoperative data sheet that includes a 9-item GERD health-related quality of life scale. This scale scores from 0 to 45, with higher being correlated with worse symptoms. We also ask each patient to rate their satisfaction on a Likert scale, including satisfied, neutral, or dissatisfied. Additional information about patient demographics and comorbidities is extracted by our database manager from the electronic health record. Additionally, from the electronic health record, we get the type of procedure that the patient underwent and the operative time. We then perform telephone follow-up at 1, 3, and 5 years postoperatively, and patients will complete the same form postoperatively that they did preoperatively, including the health-related quality of life scale and their current satisfaction. So using the preoperative and postoperative data, we performed a bivariate linear regression analysis and then included significant variables to the less than 0.2 value to be included on our multivariable linear regression model. And this was to examine predictors of higher quality of life. So our cohort included 248 patients who underwent primary laparoscopic anti-reflux surgery. The majority of the patients were female and white, and they had an average age of 55. Just over half of the patients were married and half had a BMI less than 30. 58% reported at least one atypical symptom, and 35% had comorbid depression. The majority of patients were taking preoperative anti-acid medications. So this graph shows the distribution of procedures. We do a mix of procedures with Nissen being the most common, and the operative time was pretty similar between cases. Of the patients who had an upper GI preoperatively, the majority had type 1 hernia, and of the patients who had an EGD preoperatively, less than a quarter had esophagitis and only 12% had Barrett's. Our mean follow-up time was 3.4 years, and we had a 60% telephone response rate. Of the patients that were able to report it, 80% reported being satisfied with their current condition, and the mean GERD health-related quality of life score decreased from 24.8 to 3 overall. And this graph shows just the items that are included in the GERD, health-related quality of life form, and we had a significant decrease in all items. This table shows the results of our bivariate and multivariable linear regression model. The first column includes the independent variables. The dependent variable is the GERD health-related quality of life, so a lower score corresponds to better symptom control. Thus, a negative parameter estimate is an improvement in symptoms. So in the second column, we have the results of the bivariate regression, which showed significance in male gender married patients and those without a diagnosis of depression. And in our multivariable regression model, only being married and not being depressed persisted as being statistically significant. So some important limitations to discuss. First, this is a single institution database, so the generalizability may be limited. In our institution, we probably perform a higher percentage of door and two-pay fund applications compared to national practice patterns. The health-related quality of life results can be considered confounded if you look at acid suppressive medication, because the results are regardless of whether or not they're on those medications. And the scale only includes reflux symptoms, so patients that have atypical symptoms are not going to be completely captured by that. We also did not include reoperative patients, and we don't assess complications in the database. So in our current healthcare climate, patient-reported outcomes and patient satisfaction are increasingly important. We found, depression is considered to be a comorbidity in up to 30 to 60% of patients with GERD, and we found that depression was associated with a lower quality of life postoperatively, and thus we feel that it would be an important comorbidity to screen for and to manage both preoperatively and postoperatively in conjunction with the patient's primary care provider. In addition, we found that marriage was associated with a better postoperative quality of life, and this is not really a modifiable risk factor, but if you look at marriage as a marker of social support, there might be innovative ways to increase social support for patients, including access to health psychology like our bariatric patients have, or possibly in-person or social media support groups. In conclusion, in our single institution prospective database that includes patient-reported outcomes, we found that the majority of patients were satisfied and had a significant improvement in their symptoms, and that marriage was predictive of a higher quality of life, while depression was predictive of a lower quality of life postoperatively. And hopefully I'm not offending any basketball fans with this slide. Thank you.